I've got to get different headphones. This is too much for me.
Are they?
There we go. Yeah, it's as soon as I put them on, my ears get hot. Then my brain overheats, and that's the reason why I'm not always articulate. All right, folks. Okay. So what has happened, Corey, co-host Corey, is that we did an episode about David Eby's comments that caused a little bit of a stir in the media there regarding mandatory or forced treatment for an individual that was admitted to the hospital for an overdose and then released and then admitted again on the same day. And he made some comments that...
The frontrunner for the next BC NDP leader, David Eby, says people who have multiple overdoses should be put in treatment, even if it means they have to be forced to do it. Eby made the comments on the campaign trail to Post Media, and experts and harm reduction workers say his suggestion would only do harm.
The evidence around compulsory treatment is pretty clear, especially short-term treatment, that it's largely ineffective and actually might do more harm than good, both by forcing somebody into detoxification, loss of tolerance, and potentially increasing the risk of overdose upon leaving treatment, but also just in the damage that it does with somebody's relationship with the healthcare system as a whole.
He alluded to this individual being a candidate for mandatory drug addiction treatment, which caused a big kind of backlash. And we discussed that and then received not a backlash, but very constructive questions, and questions that were, I mean, they were good questions to look at, and I think they were good food for thought. Most of them came from a physician here in Kelowna, who is a brilliant and beautiful lady who was kind enough to spend the time to go through the podcast, and she had questions that it wasn't that she was just doing it as an exercise. She really wanted to know why we were, kind of taking the direction we were taking, and listening back to it. Maybe, I don't know how you feel about it, Corey, but maybe I think I tend to get kind of caught up, and you get caught up in the political part of it. And there's part of me that wants to kind of lash out at anything that resembles a reduction in autonomy. And maybe I came off that way. I don't know. How did you feel about it, Corey?
Yeah, I mean, especially right now, I think we're approaching election season. It's easy to react to virtually anything that politicians are saying these days. And to our credit, usually it's because they're full of shit. But it is also, these are also really heated subjects. These are emotional subjects. These are subjects that politicians are not the experts on, and that anyone who has lived experience, has loved ones with lived experience, is a healthcare worker and has experienced it in their job. I think those are the people who are more qualified to have the conversation. So when we hear a politician say it, we think, well, what do you even know? And we react to that. I certainly do. But it's also a bigger conversation. We were having the conversation as a news clip, but I am so happy and grateful that we received these questions, because even without having talked to you about it, and you and I haven't really had this discussion in full yet, just in reading the questions, it got me thinking about things differently, and it just got me kind of reevaluating where I stand. And it caused me to think that there is some grayer area, as we will discuss here coming up. And then are some areas where I think, no, I don't think my position changes. But really, really good food for thought. So I'm excited to go over these questions with you and talk about them.
As am I. Yeah. So I guess the best thing to do would be to do I'm just going to run through them. So there's 1, 2, 3, 4, and then some kind of additional questions to the fourth one. We'll run through them so you get an idea of what we're looking at, and then we'll start with them and go through them one at a time and just bat them back and forth as food for thought. And then any listeners who I mean, I would love to hear people's opinion on this one way or the other. I'm sure everybody's got an experience or a take on it either way.
Yeah, I hope so.
So the first question was, how much freedom does patient X, we're going to call this this patient, or our patient X, how much freedom does patient X really have if they have overdosed twice in the same day? Interesting question, right? What is free about having to use a substance to prevent withdrawal? Is being dependent on a substance freedom? Is that are you really free if you need to take a drug every day? Another good question. Is it wrong to treat someone against their will if they're likely to die if you don't? And the physician in this case pointed to anorexia as an example. This is a condition that can lead to people just refusing to eat entirely, which can lead to their death if they're not forced to eat. So, you know, that was an interesting point to illustrate. And then when we were discussing it, I thought about how some religious groups refuse blood transfusions, and what's our, you know, we know what our response to that is morally and ethically right now in Canada, but you know, how does that fit into this picture as far as freedom of choice is concerned? This is maybe not, to some people, this would not be a rational decision, but this is this group's belief is that they don't receive blood transfusions for religious purposes, and if they die, that's their, they get to make that choice based on their religion. So another interesting case. And then this was a good one for me to think about and a good one for me to research. And she asked, can a politician in BC even get elected if they were fully on board with safe supply? And it's a good one, right? Because I mean, we could sit here and talk about how we need safe supply all day long, but realistically, can it be implemented? And on a theoretical level, the answer is yes. Like it is a federal allowance that BC has asked for. So they've done that much paperwork, and they've got it to the point where the federal government has said, yes, you can try what they're calling safer supply. They won't call it safe supply because drugs are not safe in there. There is no safe drug, even though, I mean, it's a funny place to hold your toe over the line there. They decided to throw that R on there. So for this access to prescribed safer supply in British Columbia, a policy direction that was written up and presented July 15th, 2021. So we're over a year now that this has been out. It has gotten clearance from the federal level, but it doesn't seem like anybody's, you know, there's a lot of lip service. We've seen that. And very few, to my knowledge, very few people have actually got access to safe supply. I tried as a patient and as a healthcare professional here in Kelowna. I spent a few hours just on the phone, emailing back and forth, trying to find anywhere I could go or any information even on a physician in my area, anywhere in the Okanagan where I could access safe supply, and nothing. So if there is a program that exists here, I'm not aware of it. And so what kind of we'll get to this question as our last one, but it's an interesting one, right? Can it even be done? So brilliant question. And that's what we're going to go over today. So going back up to the top, how much freedom does patient X really have if they overdose twice in the same day? So I guess you have to ask yourself, what kind of a picture do you get in your head when you hear about an individual who's had that experience?
Seemingly, the picture of someone who is, for lack of a better word, severely addicted.
Okay.
And someone who it draws up the image of someone who doesn't have choice. who's doing this almost in their own involuntary way, or that they're acting without the ability to kind of harness that.
Okay. And that's, I think after we discussed it the first time, that's kind of, the consensus was that this is a question, whether you look at it as a mental health issue or an addiction issue. And I believe, I'm starting to think that we're having a lot of problems just because they put those two in the same category.
Yeah.
It's not the same thing. Addiction is actually, there's nothing wrong with your brain. Your brain is doing exactly what it's supposed to. It's basically a bad habit has been formed, and it's a severe kind of representation of that, but it's not a malfunction of the brain or a damage to the brain or anything like that. It's not the brain acting outside the parameters of normal. So, and in this case, you have to draw the line at what boils down to cognition or capacity.
Yeah.
So, I mean, now I suppose there's different scenarios that could be taking place. Maybe this person does have an addiction that's severe enough so that they ended up overdosing twice in one day, despite knowing the dangers. They went out there, and that doesn't surprise me. But we don't know about the individual's mental health. So when I look at the situation, the first question I wonder is, why was he released from the hospital the first time? Not to throw hospital employees under the bus, but I'm just saying that there are protocols in place if this is a mental health issue and this patient was exhibiting signs or behavior that led them to believe he was a danger to himself or the public, then they do have protocols in place under the Mental Health Act that could prevent that individual from going back out of the hospital, at least for 72 hours for assessment purposes, to, kind of to keep further damage from happening. So that didn't happen in this case. He was released. What do you make of that, Corey?
Well, I think going back to what you just said about what happened in hospital, if a patient is not exhibiting any suicidality, if they are able to say, I am patient X and this is my birthday and this is who my mother is, and here's what I'm going to do for the rest of the day, and they can show that they've got that they're able to think forward, and that everything that they're saying is sort of rational and reasonable and not affected by a suicidal ideation or a suicidal plan, then I'm not sure that the hospital can hold them. If they can say, look, I took a little bit too much this time, or I used a different source than I'm used to, and they can kind of rationalize it to the team, then the team doesn't have grounds, in my opinion, to hold them. And I mean, right. we see this all the time. Like this is a hourly occurrence in most of our communities, that people are overdosing unintentionally and then are released back out. And again, I have to continue as we have this conversation to remind myself that we are living in the context of this poison drug crisis. So these are not normal circumstances.
Right.
It's not we're not in the days of where it was just heroin and the risk was that much of overdose was that much lower.
Correct. And it begs the question, if it wasn't for the current toxic drug supply situation, would this individual have overdosed at all? Or would,
yeah, totally. Probably not.
Probably not. And if real safe supply was in place, what are the chances that I don't see that anybody overdosing unless, I like we've quoted studies before that there's never been a recorded death in a witnessed injection site. Right. I mean, that's pretty wild, considering witnessed injection sites from the beginning were using street drugs. I mean, albeit before this fentanyl crisis, but still, I mean, that's got to give you some information. So if this individual was allowed to proceed with whatever, we don't know whether it's a polysubstance issue or if we're assuming it's opiates, fentanyl, but we don't know. what would happen then? Would this even have been a problem in the first place? And you could ask the same thing about the mental health situation too. I mean, we know we have a revolving door mental health crisis in this province. It's been going on for a long time. So if we had proper funding in place, if we had the proper resources and staffing, we know that our hospitals are in a staffing catastrophe right now. So, I mean, how can you expect the people in there to make a call outside of the parameters that they're in? And they've only got limited resources. So you're right. They probably, I don't know, you've probably seen many people who have been brought out of an overdose on naloxone, and they're often confused and kind of angry, right? Like, or at least displeased.
Absolutely.
Yeah. And so it could be that, and they make sense. It's not, I mean, they're a little bit fuzzy, but they're not like, I wouldn't classify them as cognitively impaired to the point of not being able to manage their own affairs.
Agreed.
Right. So, like you said, they probably assessed the individual and like, okay, well, it doesn't appear to have a mental health condition that's anything to worry about. It just had an accidental overdose, and away the person goes. So if we were to, what would a law like this look like, I guess, if you're going to implement it? And the other important thing would be, who's going to enforce this? If it can't be the police.
No.
I mean, could you imagine the RCMP in this political climate being tasked with now rounding up people who had overdosed twice in one day and, either doing, I don't know what you'd have to do. I'm assuming you would have to detain them if they've been resuscitated and are, have their wits about them again. If you tell somebody like that they're going to treatment against their will, there's a good chance. I mean, I would try to run anyway, try to flee the hospital.
Which also happens.
Yeah. Some people won't, right? They'll, maybe they've had enough. Maybe they're open to the idea of treatment, and that's absolutely fine. But the other problem that I thought about was we don't really have any evidence to support the treatment that you're sending them to. Like, how can you, this would be akin to forcing somebody with a whatever condition to go see a witch doctor. I mean, except that the witch doctor is less lethal, assuming that the witch doctor doesn't force abstinence during treatment. Because if you take somebody and force them into treatment, force them into abstinence, and then they get kicked out of that treatment center, their chance or their probability of relapse causing death goes way up because they've been resensitized to their drug of choice. These are just facts.
Yes.
Or at least what we know to be supported by evidence at this time. Maybe that'll change. I don't know. But my point is there's not a lot of evidence to suggest that any treatment is going to be substantially helpful enough to mandate something like this, let alone what we know about forced treatment or mandated treatment, which we do have evidence to suggest is deleterious to the individual.
Yeah. People have to be ready. People have to be, something has to click there. And it's sure as hell not going to click when the hospital is saying to them by force, because like, let's get specific here. By force means in many cases, because the individual will be defensive. They'll be angry if they're saying, this is it. You just overdosed. You have to stay. We're putting you through mandatory treatment. That would mean use of restraints, both chemical and physical restraints. Right. So that means strapping someone to the bed in either 4 or 5 points of their body. That will mean use of chemical restraints like antipsychotic drugs like Haldol still is used. That will require use of seclusion and isolation, which we know is not only harmful psychologically to people within our prison system, but certainly is not going to be beneficial and therapeutic to an individual in withdrawal or in the middle of a fentanyl addiction.
Right.
So like that's what that actually means. Before we can even get someone into a treatment facility, you're going to have a whole lot of issues with just trying to manage the fact that you are telling now a ton of people every single day, you can't leave here.
Yeah, that makes my stomach turn. Like
It should.
I can't. I've had nightmares about that actually, and there's something about, especially when you're talking about restraints like that and forced. I had a friend that basically got sectioned, and I don't know what. I mean, I wasn't there. I don't know what the situation was at the time, but the first thing she received was Haldol, but it was a depot form.
Yes.
And I cannot believe that like I would seek a lawyer immediately as soon as my brain worked again, which would be probably a month or two.
Yeah. People who receive Haldol, then oftentimes the hospitals themselves will give a dose of Cogentin to back off all of the extrapyramidal side effects from the Haldol, because it has such an extreme effect.
Yeah, I couldn't believe that was legal. Like I could see an acute, something to calm the person down, acute, maybe warranted if that's, if it's a situation where the benefit exceeds the risk. But who gives somebody a depot shot of a like old school dirty antipsychotic like Haldol? I mean, you're gone for at least 3 weeks, probably 4 weeks.
It's drooling, really, right? Really heavy. Yeah. And so again, going back to the medical adage of doing no harm. Physically, are we doing harm to someone? Hopefully we don't hurt them or hurt one of the employees in that process of trying to restrain them. Mm-hmm. We're giving them a drug that is going to set them back with physical side effects and psychological side effects. And now we've delayed any care because we have to get them through that sedation. Mm-hmm. And we are potentially isolating them. We are potentially restraining them. These are individuals who maybe have been through trauma and been through abuse and that we are now restraining.
Well, I don't say probably, but it's possible the individual already has some resentment towards the healthcare system for similar situations in the past, or resentment towards, I mean, lots of people, have had past dealings with the RCMP when they've reached this kind of, if you're homeless, you're addicted to polysubstances, you're usually, because of the state of our laws, you're dealing with the police more than an average person. And it's likely that many of those interactions are not positive. I'm not saying they're all negative, but that's a possibility. So if you were to, I guess you would have to somehow fit this into the existing Mental Health Act framework, but I don't know how you parse out the mental health issue from the addiction issue. And it would be my take on it would be that you can't, if it's a drug addiction problem, then from what we know, it would be best to go at it with how about you, if you stay, maybe offer them some incentives to stay in the hospital and just take it easy for a little while and give their body a chance. Like, we'll provide you with, what's your drug of choice? Fentanyl, injectable? Okay, no problem. We'll do that here. What's your dose? We'll monitor you. We'll get you back comfortable. Just relax here overnight. We'll get your electrolytes back up to, they're probably magnesium, B vitamins are probably completely shot, likely dehydrated, et cetera, et cetera. There's many kind of things we could do at that time or offer to get that person in a better spot to make a decision. And then say
now
we
we're
keep
talking.
Say we keep this person there. I mean, if you're going to use these resources are expensive, if you're going to, whether you force the person into treatment or do something where you're going to offer them something that's actually going to, potentially be more helpful. So you give the person a couple days, if you tied it into the Mental Health Act, say it was a 72-hour thing, but still voluntary. Now, I don't know, why would somebody leave the hospital if they were given their drug of choice and being monitored? And so you got your food, you're safe, you're comfortable. This is probably a good, if your MO is what the MO is for this this safer supply policy. They want to they're still focused on getting people off drugs, right?
Yeah.
So if you're hell bent on that, then wouldn't you want to go with something that's got a higher percentage chance of working?
When we're talking about, doing no harm, your proposal right there sounds to me like the risk of harm is a lot less than the alternative of strapping someone down and injecting them and isolating them and et cetera, et cetera. Like, that seems like a far more holistic, patient-centered, just reasonable, inexpensive approach.
Right. Because even from just a humanities point of view, like, how would you feel, Corey, if you were the nurse who was charged with strapping that patient down, giving them the shot that incapacitates them?
I was that nurse.
Yeah. And how does that make you feel? I mean, I was always one of the few men in the department, and I was always the biggest man in the department, size-wise. So it was like, oh, we got to take this patient down because they want to leave or they're suicidal and we have to keep them here against their volition. It always came back to me. Mm-hmm. And it's an awful feeling. It's talk about a feeling of moral distress. Talk about a sickening sort of feeling of like, what am I doing? Yeah.
What am I doing here? And then also like a really high risk, adrenaline fueled, cortisol fueled, like, it's not a good place for anyone to be in. And then the person now is really agitated and breathing really fast, and we're restraining them, which comes with risk of aspiration and risk of asphyxiation. And the nurses are kind of all wired up on the adrenaline. It's a bad scene all around. And if that can be avoided in any case, aside from the case of resuscitating someone who's overdosed, it needs to be avoided. And I think the smartest sort of practitioners out there would agree that, like, you do what you can to make that the absolute last resort.
Right. Yes. And give as much time as possible for the patient to kind of exhibit whatever requirements you're trying to parse out before you make a decision as grave as that, right? As withholding somebody or strapping somebody down or whatever you want to call it. I guess the other thing I considered, which is unlikely in this case, but I believe committing suicide is illegal. If you just decide to commit suicide, that is not allowed unless, like, they have obviously assisted suicide laws now. But if this individual was trying to kill themselves, that would be, kind of an odd outlier. But I suppose they would have to, what if this individual was resuscitated the first time and was completely cogent and said, guys, like, please, I'm trying to end my own life here, and I don't have very many resources, and you've just stopped me from doing it once. I'm asking you, can you please not, if I come back in here, can I sign a do not resuscitate or do not hit me with naltrexone or naloxone? Mm-hmm. And then you get into, is this person automatically a mental health, because technically we would consider suicide to be, you are a risk to yourself, right? But if you're sound of mind and you're making that decision, then you're into a whole different kind of territory.
And this is the exact question I was thinking about when we were preparing for this question, because it hits home for me. So one of my uncles many years ago it overdosed and was sent into hospital, and it was a sort of a polysubstance overdose. He was resuscitated, and he talked his way out of the emergency department, and was a very lovable, nice, friendly guy. And anyone who encountered him would have said that he was just a really likable person. And he had this conversation with the emergency department, and they let him go. And he went home, and within a couple of hours, intentionally overdosed again and died.
Wow.
And was brought in again. And there was enough about what my family knew about his health history, that he had multiple chronic illnesses that he'd actually been withholding from us, that he had, and certainly had mental health issues, certainly had substance abuse issues. And his life was just in a spiral. And I think it was intentional what happened there. And I think that thinking back to like, what if that was him? What if he had been that first time he overdosed, they had have kept him against his will and done all of the things that we were talking about here? For me, and I haven't asked my family members this, but for me, I think the notion of him losing that autonomy and being held against his will, and how distressing that would have been for him, that idea upsets me even more than what happened, in knowing like what the whole picture of his life was and what he chose. The thought of him being kept and being subjected to some of that treatment, and this was years ago, so the treatment would have been really coarse, even more so than it is now. That idea is upsetting to me. So again, that's just me, because I know that there are family members out there of individuals who have died in the last couple of years from toxic drugs, who say if they could have just been held there, they would have been kept alive.
Right. Yeah. You're going to get both sides of that for sure, man. That is quite, I mean, that's a kind of a crazy coincidence that you had that very thing happen. I mean, my God, I would like to hear what your parents thought about that, and what their reaction would be to having a loved one withheld, or maybe they have a different opinion. Maybe they think that he could have been assessed, or he could have been, could have had his mind changed. I don't know, but that's, yeah. I mean, that's,
I think we all kind of ended up thinking, in understanding what we learned about him, and again, that he had cancer that we didn't know about. He had a heavily diseased liver that we did know about, but that was obviously even worse than we thought, I think. I think we all kind of thought like, oh, he really didn't want all of that. He really didn't want to go through what the end of his life realistically would have been. And again, it's like getting into this discussion, it's such a personal thing for every individual, and people's backgrounds and life experience and beliefs and all of those things weigh into that decision. And that is okay.
Mm-hmm. Yeah.
But
I think that's a personal decision too. And I don't think it's people always come at it with, oh, it's a selfish thing to do. And look, man, you don't know what weight some people are carrying.
Yeah.
And I mean, isn't it kind of selfish of other people to demand that somebody stay here just so they can, not be uncomfortable? I mean, look, whatever a person is going through has got to be fairly serious if they're getting to that point. And obviously this ties in heavily with mental health, but sometimes it doesn't, right?
Yeah.
Sometimes this is just my life has gotten to a point where I'm riddled with pain 24/7. I've got all these different issues. I've reached such and such an age. Maybe the person's spouse is gone. There's a million different variables. But,
sure.
But how old was your uncle, if I can?
It was the day before his 60th birthday.
Okay.
It was on my birthday that it happened, actually.
Huh. Interesting. Yeah. Yeah. I don't know, man. How can anyone know what that individual is experiencing? I guess if you can just the same as it is with addiction related problems, you can offer the person support. You could tell them that you love them no matter what they do, and that you're always going to be there for them no matter what. And that's really the end of it. I mean, you don't jump in there and try to that's my take on it anyways.
Yeah. And I think the kind of the answer that I'm sitting with most comfortably in our conversation here is going back to what you said about just thinking about specifically for individuals in our province who overdose. Like, if we're going to keep them there, I think we better be willing to really look at the conditions and how we are treating them and under what conditions. And if we're going to make this patient centered, then we better look at the things that are actually going to be therapeutic for them and make them feel safe, make them feel heard, not make them feel like all of their autonomy, all of their freedom is being taken away.
Right.
And providing people with a space that will facilitate them to make that choice a little bit differently. Is someone going to make the what we see as like the societal norm of a right choice, quote unquote, under like an incredible amount of stress and sometimes aggression and loss of autonomy and loss of freedom? Like, are those the conditions where you make the right choice? And so
No,
that's it. You're right. I'm going to get clean now.
Yeah,
I think that's a pipe dream.
Right. And if you do, those kind of reactions are going to be suspect right away. It reminds me of when I was on rotation as a pharmacy student. We go through a hospital rotation, and I was up in Prince George, and there was a First Nations lady who came in with, she had pericarditis or something, that it was bad infection, and she'd already left the hospital well on IV. Like she required IV antibiotics, left the hospital because she was in a serious state of withdrawal. And then I guess ended up either overdosing or succumbing to that, the effects of that infection. They brought her in again, and this time they had to put a PICC line in, and they were going to dump whatever, I think it was Vanco or something, right onto her heart, basically. And I don't know what it is about that brachial line that goes, but I just find it, I don't like watching those procedures, but something about the veins, I guess. But they had a student nurse in there trying to do this line, and we were standing there watching, and they'd given this lady's already panicking. Like you can tell she's in probably the first stages of withdrawal. She's anxious. She's already starting to look at the exits, how long is this going to take type of thing, right? She doesn't realize she's going to have to stay for days to get this thing under control. This student nurse, she's doing her best, but it's just banging off the walls, and the pain, and they're giving her Ativan and stuff. And I'm just cringing at this. Finally, they get an experienced nurse in there. They get the line in, and they start it up. And the nurse who put the line in comes back to me and says, she's going to run. Like, she'll be gone in an hour. And I thought, okay, well, so this, basically, if you know that, and this is, again, there's nothing to do with the staff there. They're doing what their job is, okay? Let me make that clear. It's just that with those protocols under that situation, and sure enough, it wasn't even an hour, a half an hour. As soon as she ran out with that PICC line intact, and you can guess what she was doing with it.
For
right?
sure.
And what are her chances of survival? Man,
no,
zero. She needed probably a week of intense IV therapy with antibiotics to have a chance as it was. Now she's back out in the winter. Should be dropping whatever into that PICC line. And you think about an individual like that. So she's had this terrifying experience in there. She's going to die anyway. We completely failed. But how would that be different if you told that patient, look, let's get you out of the cold. This situation is serious here, but we're going to make you comfortable. I promise. What drugs you taking out there, to build that level of trust, especially with First Nations person who's, probably been up against the system from day one. Imagine if you could get to that point, right? Where there's enough trust there that you could make that patient comfortable, get them to a point where they're no longer dying, and then start making some decisions. But it just reminded me of that one. These are,
and when there's the assumption of moral superiority, like we know what is morally best in this situation, and us giving you 2 milligrams of Dilaudid that's going to last you for 4 hours, and you'll stay and receive that vancomycin for your heart. That has to be looked at within our healthcare system, like that moral high ground of like, we decide what is better. And that's what it kind of all comes down to, I think.
Absolutely. That was a great back and forth, Ben. I enjoyed that.